here nice and early for our start for the second day of the CMRC conference. What I'd very much like today, during our tea and coffee and lunch, is for people to reflect on what the next step is in their research. I think looking at it from the funder's point of view, what they want to see are larger, better powered and collaborative work that brings together expertise from different areas. And so if you can, please, talk to people that you've met over the last day or months or years at this conference and elsewhere, and think about how you can draw together to decide on what are the big questions that can be resolved. And think about what the priorities are. Because it may be that in the future we will have, probably will be, that we'll have limited funds as a community, and we absolutely need to think about what are the most important questions that can be answered. So I'll just quickly go through what was said yesterday. There are no fire alarms. People will know where the toilets are next to the lifts. Mobile phones off, please. I've got to turn mine off in a minute. There is filming of presentations. If those who are presenting don't wish that to be the case, please let us know. The posters will be up until the afternoon. Please do go by and have a good look. And the workshops, which are going to be mid-morning, are going to be in this room, as far as I understand. There are 3 different places in this room. And once you've finished with the workshop, if you could go straight to lunch. Good. So it's a real pleasure to introduce to you Cathie Sudlow from the University of Edinburgh. Cathie is going to be giving the Anne Faulkner Memorial Lecture. And I didn't have the privilege of knowing Anne myself, but what I understand is that Anne co-founded the CFS Research Foundation with Hugh and worked tirelessly for 20 years for a whole variety of different causes, raising for ME £2 million for 20 different projects. She was clearly a pioneer in this field of ME, but also in the wider community in asthma, and co-founded with Hugh Help the Aged. So I'd like to invite Cathie to come up and give the Anne Faulkner Memorial Lecture. Cathie is the personal chair of neurology and clinical epidemiology at the University of Edinburgh. She's the head of Centre of Medical Informatics, the chief scientist of UK Biobank, the director of the Scottish site of Health Data Research UK. Her research is in epidemiology and the genetics of stroke. She was trained in medicine at the universities of Cambridge and Oxford, and became interested in stroke in the early 1990s in Edinburgh when she was a senior house officer, and also spent time at the London School of Hygiene and Tropical Medicine, where we have others here today. So it's been a real pleasure to get to know Cathie in my couple of years since I've been in Edinburgh, and to watch on as the fruits of her labours have really been brought to bear upon a huge diversity of different disorders and traits, and I'm going to be really interested to hear from her today what she has to say. Thanks, Cathie.
Thank you very much, Chris, and thanks to all of you for having me. It's a real delight to be here. So you've heard a bit about me from Chris, so I don't have to do that bit. And you've also heard about Anne Faulkner, in whose memory I'm speaking today, and clearly she has been an extremely important person in injecting energy into research in this field. And hopefully, collaboratively, you can continue that great work and take it to greater heights. So if I can play some small role in introducing you to some resources and some ways of thinking that might be helpful to research in this field, then hopefully I'll have done research in this area some sort of small service. So I'm going to talk about 4 main things today, well 3 actually, and then we'll have a chat. So I want to introduce you to a couple of challenges in the area of big data, whatever that is, and I'll reflect on that a little bit, that are particularly important to me in my area of large-scale epidemiological and genomics research. And then I'm going to spend a bit of time telling you about UK Biobank, which is an open science research resource available for everybody to use, and something for this community to consider in terms of a potential resource that might be useful for some of your research endeavours. And it's obviously very close to my heart, and I've spent many of the last few years of my research career involved in helping to generate that resource. And then briefly at the end, because this is not my specialist area, but clearly it's very important, I'd like to draw that together and just reflect a little bit on chronic fatigue syndrome and ME and some of the challenges, and particularly the ways in which resources like UK Biobank might be useful in research into this condition, and particularly thinking about the determinants or causes of this condition, which has been generally neglected, underinvested in, and all the things that I'm sure you know far better than I do as people who are addressing these challenges. And then hopefully some time for discussion. So what's big data? It's a much bandied around term, and actually one that I sort of disapprove of because it doesn't actually have very much intrinsic meaning. So I'm going to try and attach some meaning to it. So when people talk about big data, they talk about lots of V's. So big data means large volumes of data. It means great variety of data, lots of different types from different sources being brought together, hopefully to enhance understanding of a particular area, in this case, human disease. It's data that's accumulating at an increasing pace, hence velocity, and it's data that could be of substantial value, provided we use it appropriately and ask the right questions. And data all over the world is growing in an unconstrained manner. And actually, until probably a couple of years ago, I hadn't heard of petabytes, exabytes, or zettabytes, but these are the kind of scale terms now used to describe the growth of data around the world. And I'm not sure that these have any particular intrinsic meaning to a kind of normal human being, except that they suggest that there is so much data out there that we have to be sensible and careful and scalable about the ways in which we use it. What is important is that about 10% of the data or so, according to various estimates, that are out there for our use, and this is true in health data space, are structured data. So that means they exist in what I might imagine in my mind as the rows and columns of an Excel spreadsheet, lots of ones and lots of zeros or lots of numbers that are relatively easy to analyse. But actually, a lot of the data out there is unstructured. So there's lots of information available that could be made into structured data that it would be reasonably easy to use or easier to use in analyses. But it's relatively untapped at the moment because that exercise of converting it into structured data hasn't really happened. So in health data space, that might include, for example, ECGs, electrocardiographs, which are made up of lots and lots of little bits of electrical information, which could be made into structured information, but largely they sit on pieces of paper in hospital records or on images in electronic hospital records these days. And then images that are collected in radiology settings. So here are some brain images just to illustrate that point. These are unstructured data sources from which structure has to be derived to make sense, useful sense of them in a research setting. And then an area that I've been involved in, and others in this room I know because I've been reading some of their work, have been involved in as well, is how to extract value out of all the free text that sits around in electronic medical records, in hospitals, in GP surgeries, and so on. And that's illustrated at the bottom there. So these are types of unstructured data, great potential value, but difficult to use. So turning now to some of the challenges that I think we face in this world of big data and that we really need to address, but there are also opportunities. So one of the things that I've been made aware of throughout my research career, particularly training and applying skills of epidemiology, and then moving into genetic epidemiology as well, is the need for very large sample sizes to address research questions with accuracy and power and reliability. So just to kind of illustrate that, generally speaking in medical research, most true effects, that is the association of a risk factor in a disease or the effect of a treatment on disease risk, are actually rather modest in size. People often have unrealistic expectations of a magic cure or finding the gene that will explain a particular disease. Generally speaking, that's extremely rare. Most of those kind of things have already been discovered. So we have to be realistic and bear that in mind in planning research studies. Nowhere, arguably, is this more true than in studies of the genetics of a range of common diseases, common complex diseases, and I would include chronic fatigue syndrome, myalgic encephalitis in that category. So if you think just about that, the human genome has got 23 chromosomes, it's got 30,000 genes and more than 3 billion base pairs, or something along those lines. And we know with high throughput laboratory technology now we can capture variation at all those points across the genome, at hundreds of thousands of locations. That allows us to compare people with common complex disease, who we might call cases, versus those who don't have that disease, we might call those controls, to assess whether particular genetic variants are associated with disease. Fairly simple study design, but it does have challenges. Because the effects of any particular variant on any particular disease, by and large, will be small, and we're likely to be testing lots of these risk factors across the entire genome simultaneously, because that's the best way of discovering the entire genetic architecture underlying a disease. So to do that, we need very large numbers of cases and controls, in the thousands, or the tens of thousands, as it happens in empirical experiments. And we need, therefore, stringent statistical testing rules. Now, I don't propose to go into the details of all the kind of numerics behind that, but just to illustrate that from an area that I've been involved in, to find the first well-established genetic locus that had an effect on ischemic stroke, it was necessary to collaborate globally to bring together information on 10,000 cases of ischemic stroke compared with 16,000 controls. And here is a plot that at least some of you will be familiar with, and you may have seen some of these earlier on during the meeting, and apologies that I wasn't here yesterday. But you can see here are all the chromosomes, human chromosomes, and each dot here denotes the p-value or statistical significance of association between variation at one point along one of these chromosomes and the disease. In this case, this is cardioembolic stroke, which is one subtype of ischemic stroke. And essentially, the field generally considers that if the statistical significance is above this line here, that one can claim that there's an association between variation at that point and the disease in question. And this gene here, HDAC9, was the area where there was an area of variation that was associated with ischemic stroke in this very large study. So a big effort, and you might sort of shrug your shoulders and think, well, so what does that mean? How does that help? Well, it doesn't help very much on its own. It only starts to become helpful, I would argue, when you increase the sample size even further and you start to get a better idea of what's really going on, what's lying under those areas that you didn't have enough power, statistical power, to comment on. So this is the next phase of this international consortium, bringing together now 67,000 cases of stroke and nearly 500,000 controls. And you can see with that kind of sample size, there are lots of areas across the genome that are associated with risk of stroke. And many of those were already known about from previous studies that had been pretty large, but some of them, when this very large consortium was brought together, were completely new. So, sorry, the ones in red are new, and the ones in black were the ones that we already knew about from somewhat smaller studies. And that's important because it's only when you reach these kind of sizes that you start to get an idea of the whole genetic architecture of disease. And even then, in general, we're studying rather common variation in the human genome, not so much rare variation, and there are different approaches required for that. So the details don't matter too much, except that it's clearly very important to have the capacity to study very large numbers. Again, so what? So by understanding the genetic architecture of disease, it's possible to start to disentangle some of the mechanisms of that disease that we might not already know about. Now, stroke, actually, we already know quite a lot about what some of the causes are. For a condition like chronic fatigue syndrome, ME, we actually know a great deal less. So the need for this sort of approach for a condition that's been generally under-researched is even greater, I would argue. Also, we're starting to find, where there have been studies of this size, that contrary to my kind of skeptical view, it is actually possible to combine information across the genome of a particular individual to predict what their likely risk of disease is going to be in a sensible and informed way. And there's some recent publications that suggest that this is likely to be useful, potentially in a clinical setting, for predicting risk of myocardial infarction, for example. So again, with large numbers and a great deal of effort, it is possible to start to disentangle the uses of some of this information. Now, another area that's important is getting the design of studies right. And if you want to understand the causes of disease, there are great advantages in doing prospective population-based studies. And I'm just going to outline why I think that's the case. So if you take a large population of individuals at some sort of age, and let's, for the purposes of what I'm going to talk about later, say that these individuals are in middle age at the time of their recruitment to the study, and by and large they've been recruited from the unselected population, so most of them will be walking around and pretty healthy. Some of them will have a history of the disease. Many of them in the future will develop some sort of disease across a whole range of different conditions. By recruiting them, establishing all sorts of information about them at baseline, and then following them up, one creates a prospective study design that enables questions to be asked about what causes some people to get sick from a range of different conditions, and why is it that some people don't develop disease. So that's an expensive kind of study to do. You need to recruit and study, you need to recruit and gather information from very large numbers of individuals so that enough of them will develop any particular condition that you might be interested in studying. And one doesn't want to will it on them to develop those conditions, but when it comes down to it, it is about numbers. The advantages are that you can measure the potential risk factors or things that might cause disease before, and in some cases long before, disease develops. And that means that you can disentangle the chicken and egg situation. You can avoid what we call reverse causality. You've measured the potential causes of disease before the disease happens. Otherwise, some of these things you might measure could be influenced by the existence or the occurrence of disease. And it's particularly important for studies of non-genetic risk factors. Genes don't change when you get disease, but just about everything else does. Another advantage is that if you want to compare people who have disease with those who don't to understand causes, so that's what we might call cases versus controls, then if you select the controls from the same population the cases come from, that means that your comparisons are far more likely to be valid and reliable and give you information that you can trust. And another advantage is that the effects of a potential risk factor can be studied on not just one disease, but across a whole range of different diseases. So just to illustrate that, for example, there's been great controversy about whether it's a good idea or a bad idea to take the pill or to be on hormone replacement therapy, because it seems that it makes some things riskier and some things less risky. And it's only in this sort of study that you can get a balanced view of overall what's the effect on a range of different diseases. But these kind of studies need to be large, as I've said, and because only a proportion of the participants in a study will develop any particular disease during follow-up. So we can illustrate that if you take a random sample of a number of people from a very large collection of prospective studies before there were very big prospective studies. So this gathered together information from about 1 million people who'd been followed prospectively from middle age forward. And this looks at the risk of blood pressure and subsequently developing coronary heart disease, so at different ages. And this is what the information looks like when you analyse it with respect to 5,000 people drawn randomly from that prospective cohort. So what you can see is that, and this is risk on a doubling scale here, and this is blood pressure along the horizontal axis, systolic blood pressure. You can see there's a general kind of trend for risk to go up with age. Each risk age group estimate is plotted as a little dot, and its 95% confidence interval or precision is shown as a vertical line there. So you can see that none of these estimates is very precise. There's a general sort of sense that older people are at higher risk than younger people, and the patterns might be different in different risk groups, but it's really in different age groups, so it's really difficult to tell. Now, rather like kind of turning up the power on a histopathologist's microscope, if you then take a 50,000 person random subset from this data set, then you start to be able to disentangle what these risk patterns look like. And you can see that generally, with an increase in blood pressure, there's an increase in risk, and the different age groups are starting to separate apart. But it does look rather as if, at the top end of the spectrum here, at higher blood pressures, people in older ages are starting to get a flattening off of that increase in risk. And it looks down here as if people in younger ages are starting to get an increase in risk at lower blood pressures. But again, you can see from these vertical lines that the precision of these estimates is not very great. We don't actually really know whether that's the pattern or not. But on the basis of this sort of observational information, people in older age groups were effectively denied blood pressure lowering treatment for a long period of time. And it's only when you study very large numbers that these relationships really start to tighten up and become much, much clearer. And what you can see here is that this relationship, which is log linear, continues throughout the range of blood pressure studied. And there isn't actually any evidence when you study decent numbers for any flattening in this age group or for any kind of J-shape at the bottom of this age group. So just an illustrative argument for why studying large numbers of individuals can be highly informative. For population-based prospective studies, you also, for many conditions, need long follow-up, particularly conditions that emerge slowly, that may have a long subclinical prodrome before they become apparent. One of the conditions that I've been involved in studying that has that characteristic is dementia, because people are starting to develop dementia probably 10, 20 years before it becomes manifest. And so if you don't follow people up for a very long time, from the period at which you collect the information about them at baseline, you run the risk of getting erroneous answers to questions. And that's illustrated well by this study here of 1.3 million middle-aged women who've been followed up now for 16 years on average, and some of them many more. And amongst them, they've developed 24,000 of them have developed dementia, so we call these the 24,000 cases of incident or new onset dementia. And just to show how the associations with risk factors look with different periods of time after the initial information is gathered from these individuals. If you look at two risk factors, smoking and physical activity, and these are shown as relative risks here. Each box shows a relative risk, and the horizontal line is the 95% confidence interval. So for smoking here, you can see that the risk increases as smoking increases of dementia, but those risks become much stronger with longer term follow-up, probably because smoking status is actually changed in people who develop dementia early because it's already started to change as a result of the disease having started before you collected the information. Physical activity is even more interesting because if you look in the first 10 years after baseline, it looks as though physical activity is associated with dementia, and because it's been measured before apparently the dementia started, you might believe that that means that if you exercise more, that will protect you against dementia. But actually, if you look at the cases that emerged more than 10 years after baseline, there's virtually no association at all. So much of this apparent association might be because people who are starting to develop dementia, even before it's manifest, are not as physically active. That's what we call reverse causality. It's an important phenomenon. Now I'm going to tell you a bit about UK Biobank. This is one of the things I really like talking about. It's a study of 500,000 men and women in the UK. They were recruited in middle age during 2006 to 2010. And they gave consent for all types of health-related research by a range of different research communities, academic, commercial, charitable partners, and so on. So very broad consent. And they answered extensive baseline questions and had a whole range of physical measures done with biological samples stored in millions of aliquots for the potential for future assays to be done to look at the effect of a range of different biomarkers, some of which we know about now and some of which we don't know about yet, but might be interesting, and look at their relationship with future disease to help understand disease. Subsequent enhancements in all or large subsets of these participants have been done, and those include, for example, collecting data from portable wearable devices, so accelerometry data to tell us objectively about their physical activity in very large numbers, monitoring of the heart to tell us about cardiac rhythm, both clinically apparent and subclinical in 20,000 or so of them, and that number will hopefully grow. There have been a number of sample assays done on the samples, including genotyping, genome-wide genotyping of the entire cohort, and a biochemistry panel applied to the entire cohort, and a number of genomic assays now underway to interrogate the genome in much more detail, exome and whole genome sequencing, with other biomarker assays, including proteomics, infectious disease assays, metabolomics, and potentially stool microbiome being planned at the moment. One very exciting component of this study is that we've launched and are now well underway with a multimodal imaging study of 100,000 of the participants who are being re-invited back to centres to have this imaging done to help understand how body structure and function in various different regions of the body may influence future disease in combination with all the other information that we've got about these individuals. Web questionnaires are helping us to gather additional information from individuals where there wasn't time or resource to collect it at the baseline visit, and that's been a very useful, scalable way of collecting additional information about them. And then these individuals are being comprehensively followed up long-term for a wide range of different health-related outcomes. And importantly, it's an open access resource. So anybody here in the room who considers themselves to be a bona fide researcher, and I should think that applies to many of you, most of you, can apply to use this resource in their research. And essentially, if what a researcher wants is access to data for a legitimate research question that's in the public interest to have addressed, then we say yes. And they can have access to pretty much the entire data set if that's what they need to enable them to address the question. It's not free, but it's extremely inexpensive. It costs basically a couple of £1,000 to have pretty much the entire data set. It's been very, very, very expensive to build this resource, although very cost effective to build this resource as well. And it's been possible to do it because of the willingness of hundreds of thousands of volunteers across the country, and major investment and foresight from major funders, including Department of Health, the MRC, the Wellcome Trust, a number of charitable funders, and the Welsh and Scottish Government as well. So these individuals were recruited from about 22 centres around the country, mostly from England, but substantial subsets in Scotland and Wales as well. And this is quite fun because I wasn't actually around at the time that this recruitment was going on, but I really enjoy hearing about it because it required industrial scale processes to actually manage a project of this size. So just to illustrate that with respect to the samples, at the time of recruitment, When it was at full pelt, there were 6 centres open at any one time, and that meant that 700 new participants were being recruited every day. That led to about 5,000 tubes of various bits of sample being filled per day, and in this case it was blood and urine and saliva, which were aliquoted into 25,000 aliquots and sent to a very large laboratory, generating 15 million aliquots, all barcoded and able to be linked back to the individual and their data to enable research studies to occur. And these samples are held in a large laboratory at the Biobank Coordinating Centre, which is not in a beautiful university or in an NHS facility. It's on an industrial estate in Stockport, just outside Manchester, opposite a police station, which is kind of pretty handy because this is a very, very valuable laboratory. And these samples, all the aliquots, are all in this massive laboratory where journalists who occasionally wrap up warm and go inside stand to the height of about here. So that gives you a sense of how big it is. And all of these shelves hold masses of aliquots of sample, which can be selected automatically according to characteristics by this robot here. So these samples are kept at minus 80 degrees and they're kept cold by circulating liquid nitrogen. And this little chap here, who's the robot who selects the samples, can only operate at temperatures of minus 20. So the railway up and down which the robot roves to select the samples, with its little arms going out and pulling them into trays, is at minus 20. So you can actually go inside there, but it's pretty chilly. You have to wrap up warm. So what does a resource like this generate? And I'm illustrating this with respect to a range of different diseases. So we predicted at the beginning, and we were reasonably accurate actually in that during the course of follow-up, very large numbers of major conditions that were going to be of interest to study would be generated. But actually, through self-report at baseline and interrogating the emergence of a range of other conditions, we've demonstrated that it's possible to study just about anything that might affect somebody in middle age or later life with reasonable numbers, depending on the rarity or commonness of the condition and the length of follow-up for new cases of that condition to accrue. But you can see here some of the commonest ones. There are no surprises. They represent cardiometabolic conditions, cancers, and other common chronic diseases. And interestingly, you can see that some diseases, which you might expect to be relatively rare, close to the beginning of the study, start to accrue much, much larger numbers as follow-up continues. So just to tell you a little bit about some of the additional data gathering, this is the accelerometry project, which has gathered data from 100,000 individuals, which is now being actively used to study associations between physical activity and health, and could potentially, I think, be used to interrogate objectively gathered physical activity in association with various symptoms, fatigue, etc., which may be relevant to the studies that this research group might be interested in doing. And additionally, the cardiac monitoring study that I alluded to a little bit earlier. These kind of data collections do create major challenges, which is why a global community of researchers is necessary to maximise the value of Biobank, and why an open science approach is the only sensible approach when you're building a resource like this. Because you need scalable methods to analyse all the data that you get into the resource from these types of data collection exercises. We can also collect data using web questionnaires, which is a really handy way of gathering information from people at scale. So we've got email addresses for about 350,000 of the 500,000 participants, and we can email all of them, all of those people who are on email, pretty rapidly. I make it sound much easier than it really is. And that means that they can complete web questionnaires that we make available to them online to gather additional information about them that might be of interest. We have to make the questionnaires reasonably short, we have to make them fun, or it's certainly not too tedious, and that gets reasonable response rates, so that every time we do one of those exercises, about 150 to 200,000 sets of replies come back to us within a matter of weeks. So that's pretty helpful in terms of generating additional information that can be linked into all the other information in the resource. For example, we've used it to gather details of dietary intake, to track cognitive function over time, to gather information on mental health which is really not very well gathered through health record sets, which I'll come on to in a moment, because people often don't talk to their doctor about these types of symptoms, and to gather information on gastrointestinal symptoms. We have forthcoming questionnaires which will give additional information on pain and quality of life and other really important features of health outcome which are not gathered well through traditional linkages to medical records. And then some of the sample analyses I've spoken about already, so I'm going to skip over that slide. Just a little bit about our multimodal imaging project, which is also pretty interesting and challenging. So 100,000 participants coming back, and they're having mainly MR scans of the brain, heart, and whole body to gather a whole range of different information about organ structure and function. And they're also having carotid ultrasound imaging, which gives information about vascular disease and vascular risk factors, and bone densitometry or bone DEXA scanning, which gives information about bone and joint disease as well as bone density. And that's been a very exciting study, mainly because of its scale, because multimodal imaging studies had not previously been done in more than about 5,000 or 10,000 individuals. So this was very ambitious, and already during recruitment, it's become the largest multimodal imaging study of its type, but linked in with all the other information, it really does, I think, add major value in terms of the research potential to address questions. So following up all these individuals, that's been a pretty major challenge, and as one of the, well, as the really only practicing clinician in the study team, it's really been a job for me to think about how that should be done, and this has been one of the major challenges. So our aim's really been to identify a wide range of people who are developing disease during the course of follow-up, and a range of other health-related outcomes as well. Traditionally, cohorts use active methods to follow participants up, and that means getting people back for a face-to-face reassessment, doing postal or web-based surveys perhaps, and we've done some of that in UK Biobank as I've shown you. And that means with electronic capture you can acquire data very rapidly, but you never get everybody to come back. You never get everybody to answer a questionnaire because they'll be busy or they'll be unwell, which means that the answers may be actually quite selective, or maybe they'll have developed disease, or maybe they'll be dead. So it's a very useful way of getting detailed information using active follow-up, but it does have inherent limitations. And you tend to miss things that happen between assessments. The other thing is, it's extremely expensive. So to do that kind of thing at scale is really very challenging. And it's worth, therefore, thinking about passive methods that can be used to follow up. And one of the things we can do in the UK, but which can't be done in many other countries in the world, and arguably can be done, if we do it well in the UK, better than almost anywhere in the world, is to follow participants up without the need to hassle them or re-engage them. It's nice to be able to re-engage participants if that's what they want, and we do a lot of that, but it's nice also not for participants not to have to put in too much effort after they've already come along and given up their time to be recruited to a study like this. So it should make it efficient and cost effective, and to a large extent it does, although it's really much more challenging than one might imagine. You need to have broad consent at recruitment to do this sort of thing, and it does rely on a universal healthcare system, which we just about have in the UK. We're kind of clinging on to it, aren't we? And one can only, of course, detect cases of disease that are diagnosed in a healthcare setting, and I think that's, in terms of thinking about health record linkage studies in general, that's a challenge, and I would say it's a challenge for a condition like chronic fatigue syndrome and ME to think about where would you best find information about people with this condition in these very large nationally covering data sets, and how valuable is it likely to be. And there are people in the room who've looked into that in much more depth with respect to chronic fatigue syndrome than I have. And the data are not collected for research. They do need to be accurate and sufficiently detailed for research studies, and we've been doing a large program of work around that. So to follow up the 500,000 Biobank participants, we've been getting regularly updated information on a wide range of diseases from NHS datasets in all 3 countries. So we link to the death registers, and we know that that about 14,000 of our participants had died by early 2016, for example, and we've got information about what they died of, and through the death certification scheme. We know about a wide range of development of cancers, with information about the date, the stage, and the grade of cancer, and increasing depth of information becoming available through the National Cancer Registration System. We also know about admissions to hospital, so there are good linkages around the country that you can make to all the hospital consultations that occur and all the hospital admissions that occur, but the ones that are diagnostically coded or that have procedure codes attached to them are the inpatient ones. So there is a gap in terms of the information from outpatient hospital visits around the country in terms of the national data sets that one can link to. But nonetheless, through the admissions to hospital, one can gather information about thousands of cases of many, many diseases. And then we have been very, very keen throughout the whole time that I've worked with Biobank to link at scale to primary care data, because it's through consultations with primary care that we're going to uncover information about a whole range of conditions that don't necessarily get anywhere near hospital, and particularly don't necessarily lead to admission to hospital, and certainly not until very much later in the course of disease for many diseases. So we've, with a great deal of effort, been able to do that for about half of our participants, and we're carrying on and trying to do it for the whole lot. And I'm not going to share how painful that's been with you to try and do that, but we have been able to get a lot of information so far. So just to illustrate the value of primary care with respect to a number of conditions, and you might be thinking about, well, what might this mean for chronic fatigue syndrome, and how valuable might primary care data be for studying chronic fatigue syndrome? With respect to dementia, for example, you can see the numbers of cases that we had at Recruitment, mainly through self-report, and you might, not very many through self-report at Recruitment to a study like Biobank, quite large numbers of cases of other diseases, with questions about how accurate self-report might be, so important to understand that. And then the numbers of cases that were observed by 2016 and numbers that we predict based on that will emerge in the future. Then if you look at what happens if you add in primary care data to the mix, because these are based on what we get from the hospital and death registry linkages, the numbers for some of these diseases more than double. So Parkinson's disease, for example. And I'll come back to that just at the end with respect to chronic fatigue syndrome. So maximising the value of data like this is really important. They're messy, real-world data. They're not collected primarily for research, but they can allow us to get information at scale, very important. They're not 100% accurate, for sure, due to a combination of administrative and actually clinical errors as well. The clinical errors are larger than the administrative errors, by and large, is what we've been finding. And they're coded to various international or national coding schemes, like the International Classification of Diseases, or READ coding, for those of you who are familiar with it, in primary care data sets, which is a very, very challenging coding system to extract really useful information from for research purposes. So we've developed a number of working groups in a range of different areas to advise us on the value that we're likely to get out of these data sets, and to help us extract the code lists that are most likely to be informative. And this is an ongoing piece of work. We're kind of picking off disease by disease as we go, trying to scale up, trying to get more efficient, trying to extract value out of these data sets that we link to, so that researchers can use them more readily and more quickly. So combining information from the different data sources to create kind of disease status indicators, if you like, with known reliability. So we're also trying to study how accurate these algorithms are for identifying disease by making comparisons with various reference standards. So, for example, this is just some work from a systematic review that we published recently showing the accuracy, and I'm using the metric here of positive predictive value. That means out of all the cases that are identified by using a particular healthcare data set or a combination of data sets by extracting the codes that are likely to mean that disease exists. How accurate is that really when you compare it with an expert-driven reference standard? And you can see that there's a great range of accuracies across a range of different studies from these different types of data sources. But for quite a large number of these studies, there's reasonable accuracy in excess of about 80%, which for large epidemiological studies might well be quite enough for generating really interesting results about the causes of disease. It might not be good enough for diagnosis in clinical practice, although arguably in clinical practice we often don't do very well at diagnosing many diseases either, and I think it's really important that we are aware of that. So when one delves into subtypes, and here I'm using dementia again as the example, you get some interesting things emerging. So Alzheimer's disease, for example, tends to be encoded much more accurately than vascular dementia, and there's a range of different reasons for that, partly to do with the level of understanding of the disease. And we've done a number of small-scale validation studies based directly on the Biobank data by comparing these codes with full free text of the medical records to look at how, and having experts adjudicate for us, to look at how accurately we're picking up some conditions. And I'm just illustrating that for a few conditions we've looked at, which include dementia, Parkinson's disease, and stroke. And just to summarise the information that's emerged from that preliminary exercise, these within a biobank context, these sources for these diseases anyway are not performing at all badly. So we're getting positive predictive values of in excess of 80% and sometimes in excess of 90%, sometimes a little bit lower. Primary care codes, which I was somewhat sceptical about, actually perform really pretty well. Look, 95% here for Parkinson's disease. And that's because primary care codes tend to be entered by medical professionals on the whole, and they do tend to capture the entirety of the information. So if a patient is seen in a specialist outpatient service, the coding from that specialist outpatient service is likely to make it into the primary care record. So actually, this just illustrates the value of linkages to primary care. And I think there are people here who understand a lot more than I do about how valuable primary care resources at scale might be for identifying cases of chronic fatigue syndrome and related conditions. So going beyond the linked coded healthcare data into the unstructured data could also be a very interesting thing to do across a range of diseases. So I'm talking about some of these things we spoke about earlier, free text, ECGs, histopathology slides of tumours, for example, radiology imaging. So getting access to those types of data at scale, though, is really very significantly challenging because of information and governance and security concerns, even if one has consent, and because of perceptions of safety of transfer of these types of data outside of NHS systems into a research environment, even if they're de-identified, and because of the technical challenges of retrieving these types of data at scale from a range of different potential sources and data providers. And then, as I alluded to earlier, doing sensible things with them at scale also requires a massive effort. And it's organisations like Health Data Research UK who are bringing together the individuals and the training under the leadership of Andrew Morris that I think are going to help move the field forward in this regard. And so I think engaging with organisations like that as well is a very useful way of understanding how large-scale data resources might be useful for examining causes and treatments of under-researched conditions. So just coming back to Biobank, just to give you a flavour of who's using it, so this is the end of 2017. These numbers are now substantially larger, but by then there were 6,500 registered researchers. There's now well over 7,000. They are all over the world. Hundreds of research projects. This number is now in excess of 500, I think, in terms of numbers of publications coming out. And those of us who are building the resource, I have no idea what's being published. I just can't keep up, really. But it's all listed on our website if you're interested. So I am not involved in all of these publications. It would be crazy to be involved in all of them, although I do get involved in some of them, I'm pleased to say, and that's really good fun. And you can see as well that the research community, which started off in the early days when we opened up the resource, as mainly people from the UK, is becoming increasingly international. So this resource is capturing the imaginations of the global research community. And while that has been a little contentious on the whole, I think that's a very good thing, because the power of the global brain is being applied to this resource that's been generated in the UK. It's a real showcase for what the UK can do. It's attracting inward investment from industry, from our funders and from others. So while some people do see this as a bit of a threat, it's actually, I think, a very positive thing that we have such a broad international interest. And people are doing research in a very broad range of areas. Lots of research on genetics of disease, lots of research on imaging factors in disease, cognition, cardiovascular disease, multimorbidity. There's no mention here of chronic fatigue syndrome or ME specifically, but there are research findings emerging about that condition, and I think there are potential great opportunities, although this might not be the resource that answers all or indeed most of your questions, but it's an illustration of the sort of thing that can be done. So briefly now, just some reflections on the condition that's of interest to everyone here today. So with respect to Biobank, how many people in the Biobank resource have chronic fatigue syndrome or ME? Well, the bottom line is we don't actually know. So those who self-reported it, about 2,000 or so, and I can see there's a lady in the audience who's clearly one of the Biobank participants, so thank you very much. There are probably others as well. Maybe we should have a show of hands. Are there any Biobank participants? I've spotted, oh yeah, quite a lot of you. So thank you very much. You are amazing people. Look what you're doing. And some of you might fall into this category. We don't know how accurate self-report is for chronic fatigue syndrome. There may be people in the room who can reflect on that, but that's an important caveat. And when I last looked, there were less than 100 cases that had emerged through the hospital admissions data linkages. We haven't been able to look yet at what's emerged from the primary care data linkages because we're still pulling in those data and doing preliminary explorations and waiting and preparing very hard to get them out there. But I would be very confident that this number will increase massively once we bring in the primary care data, and even then we will not be capturing all the information about this condition. So primary care is going to be very important with respect to studying this condition. I think there are significant challenges of defining and identifying this condition as I understand it, and I've done a bit of background reading, but this is not my home territory, so I defer to you in this research community to think about that and how one might apply standardized definitions or a range of different definitions to look at what that might mean in a research context. In terms of studying the causes, what's the relevance of UK Biobank, which has recruited people in middle age? So it's probably useful, particularly useful for studying later onset chronic fatigue syndrome, but as I understand it, it's a condition that generally starts earlier in life. So there will be really interesting retrospectively gathered information within the Biobank cohort that's useful, but it's worth reflecting on that chicken-egg causal pathway thing that I spoke about at the beginning and thinking about whether there may be other resources of this sort of scale or similar that might also be helpful in studying the causes of chronic fatigue syndrome. There is some tantalising initial results that are emerging from UK Biobank, and if there's time, Chris might want to tell you a bit more about the detail of those, but it does look as if there may be some genetic associations with this condition based on cases retrieved through the self-report mechanism. I would say those results are preliminary for a host of different reasons, but it does suggest that there are definitely potentially some signals worth following up, but also the potential for further studies as the numbers from primary care emerge and there start to be larger numbers to study within this resource. And as I've spoken about, there are other large-scale resources and opportunities, and very happy to discuss those at this time. Thank you very much.